I guess this title, "What's in a Name," is a topic that's being hotly debated all over the world, and particularly since ICD level 11 came up with the diagnosis of complex PTSD. So I think from our point of view, it's of theoretical importance because we follow the DSM-5. And through the course of this talk, I'm going to also look at some of the differences. Now, there's this debate about the validity of the complex trauma stress disorder diagnosis continues. And I think we have to remind ourselves that it's all about psychological trauma. And psychological trauma can lead to significant distress. It can lead to functional impairment and the development of trauma-related psychological symptoms. So what we are disputing here really is how we diagnose trauma-related psychological symptoms and how we cluster them and make these various diagnoses. We're all familiar with PTSD as a reaction to trauma, and then there's a collection of symptoms that arises as a result of trauma. But I guess PTSD originated mostly as a result of impersonal trauma. And then after the wars, the Vietnam Wars and the World Wars, when veterans were returning with huge reactions of re-experiencing avoidance, arousal, reactivity, and quite a wide range of psychopathology, that PTSD came into our nomenclature, and we were very used to that diagnosis. And then we began to be used to the diagnosis of borderline personality disorder. And when we look at borderline personality disorder, I want to remind ourselves what is a personality disorder. Now, personality disorders are enduring patterns of inner experience, ways of thinking and feeling that deviate markedly from the expectations of the person's culture, that are inflexible and are pervasive in a broad range of social situations. But most importantly, they affect the individual's way of thinking about self, others, or events, as well as emotions, interpersonal functionings, impulse control, and then lead to subjective distress and cause considerable impairment in social, occupational, or other functioning. So when we look at personality and then borderline personality, if some people have symptoms of PTSD, we make the diagnosis of PTSD and borderline personality disorder. However, ICD-11 has kind of put a spanner in the works and has changed that to complex PTSD. So what happens then to borderline personality disorder is the question. So why the controversy? When the symptoms of BPD overlap with those of PTSD and other access to disorders, they were raised. The other aspect of the controversy was that people said that patients are so diverse, making BPD a waste paper diagnosis. There was an attempt to get rid of the diagnosis of BPD. The dearth of support in the literature regarding the reliability and validity of BPD as a diagnostic entity was also another reason. Now, I think that to me, the reading of the literature and the discussions I've had with people at conferences and seminars, etc., are that the personality disorder diagnosis provided negative connotations, which a lot of patients, carers, as well as people with lived experience felt that those negative connotations needed to be removed. Now, I appreciate that some diagnoses have negative connotations, But in course of time, I'll also tell you why I think that if we did that, if we removed that diagnosis, we will actually be doing a disservice to our patients, because we will actually be withholding proper treatment from them if we follow evidence-based practice and if we follow the diagnostic guidelines. So the answers to the controversy, the symptom complexity is not well represented by the diagnosis of PTSD. The consistent reported association with cumulative childhood trauma, namely sexual abuse and physical abuse in particular, adds complexity to the PTSD when it was thought to be a solution. And in addition, the genetic neurobiological factors brought out by childhood trauma were also other reasons that were given to answer to the controversy. If you notice that all along in the discussion, CPTSD has made reference to cumulative childhood trauma, chronic trauma, physical abuse, and sexual abuse. And that in making the diagnosis, that history of abuse might not be available at the very beginning of an assessment. But to me, what has been left out is emotional trauma and attachment trauma, which to us as therapists, when working with such people, we want to bring that out, and we are usually trying to work with attachment trauma and emotional trauma, the ideas of shame and depression, the ideas of guilt and depression, guilt and shame, etc., as a result of early chronic emotional abuse, devaluation, chronic shaming, criticism, and attachment trauma are vital to our work as psychotherapists, is kind of sidelined. So single incident or repeated incidents of impersonal or interpersonal trauma results in PTSD, though not everyone develops PTSD. Whereas cumulative trauma from an early age has the propensity to alter personality development, resulting in BPD. And chronic interpersonal relational trauma of one or several types has the propensity to develop complex PTSD if the relevant symptoms of PTSD are present. So BPD can be present with complex PTSD as well as with PTSD.